to, I think this is the 6th acute pancreatitis patient registry to examine novel therapies in clinical experiences, what we call APPRENTICE webinar. Today is Saturday, January the 23rd. I would like to update you in where we are right now and move forward. Amir, if you don't mind advancing one slide. So the agenda of today's webinar will include our review with our experience with the pilot phase. The pilot phase is let's say, the initial few months of the study, where due to IRB issues, we're only able to enroll and involve centers from the US. So 7 centers from the US have been capturing and enrolling patients with the idea to see how smooth the process is, to try to optimize as possible the database and see if there are any flaws or any problems with the use of our electronic capturing system for the database, the REDCap. In addition, we will update you on the international participating centers. Many of them are ready to go, and that's why we're doing the webinar today. And there are still many more that they are very close and they have initiated the process, but still we don't have the final IRB approval letter from their institutions. At this point, then Amir will take over and he will discuss with you tips on how to start enrollment through REDCap. As we have already established the last few weeks, there will be a weekly progress phone call conference. So every investigator, as well as the research coordinator that is doing the daily job, will have the opportunity to share with us his or her experience, as well as any questions and issues that they will come up. We will also review a sample case data entry. Amir will do that with you, how to enter the data and how to extract the data, as well as how to monitor the data. Amir, if you don't mind advancing into the next slide, the pilot phase. Unfortunately, I am connected through phone, so I do not have direct visualization into the slides that come up on the webinar. Of course, I do have the presentation in my computer. So in respect to the pilot phase, as I briefly mentioned, there have been 9 centers involved. This is an ongoing project now for almost 2 months. Each center has set up, each center has enrolled 1 or more patients, and I think we might be a little bit higher in patients right now. We might be close to 25 patients enrolled, which is not a huge number, but clearly does show to us the feasibility of the project. The vast majority of the patients have been enrolled from the University of Pittsburgh side, and this is in a way expected because, as we have discussed in the past, we did have the mechanism set up and active for years, so it was very easy for us to keep on doing it and enroll patients to Apprentice. I do completely appreciate that there are difficulties in other centers, especially in the beginning. However, I'm very optimistic for the study, and I do believe by involving some high-volume centers throughout the world, we'll be able to start cranking larger numbers. We have received many comments on questionnaire structure and specific variables. Overall, I have to tell you that the questionnaire is working very well. Amir and myself, as well as with our collaborators, are now in the process of fine-tuning a few questions so as to make it as smooth as well as time efficient as possible. So as I mentioned, REDCap is feasible, is convenient and applicable, and is a great tool in our hands. The feedback from the other coordinators was that it is a convenient system, and they are very happy with the progress and how REDCap exactly works. It does save time. the data is very clean when you enroll them. So it's a great tool in our hands. Amir, if you can advance to the next slide, we're going to move to the collaborative centers. The centers that have already been approved and have been involved in the pilot phase are 9 centers from the U.S., including the Medical University of South Carolina, Johns Hopkins University, with the great help and support of Dr. Vikesh Singh, Stanford University, with Walter Park, University of Nebraska, University of Indiana, University of Tennessee, our center, University of Pittsburgh, as well as Cleveland Clinic and Brigham and Women's Hospital at Harvard in Boston. So I'm extremely excited about the participation of these 9 centers. And as you can see, these are major academic institutions with a great reputation and tradition in pancreas research. I mean, it's a great honor to have centers like Brigham and Women's and Hopkins, Cleveland Clinic, and all the others, of course, Stanford University, so on and so forth, involved in Apprentice. So we are extremely excited and honored, and at the same time, we do understand and appreciate that this is an enormous opportunity right now to work hard, dedicate time and effort so as for Apprentice to be a successful study, and this can be the initiation of many other studies to follow that can be not just observational studies, but at some point also randomized controlled trials. Amir, if you can advance to the next slide, please. Yes. So in respect to the international centers, I'm happy to inform you that the Institutional Review Board at the University of Pittsburgh has approved the international study, what we call Apprentice 2. Apprentice 1 is mainly the study involving the centers in the U.S. because the process of starting a study through the IRB by just involving the centers from the U.S. was much, much faster. That's why we followed this approach for the pilot phase. But now, as you can see, as for late December 2015, even the international apprentice study is approved. So all the participants in this webinar, all the centers that reviewed the invitation for this webinar can now start enrolling patients after creating their REDCap accounts. So we are almost not even a step from start enrolling. You just need to create your REDCap accounts. And at this point, Amir has a lot of experience with REDCap, has already guided 9 centers in how to do that. So this is a very well established process without any issues. Amir, if you don't mind advancing one more slide. So approximately late February of 2016, we hope that we'll be able to launch the main phase of the study. At this point, all enrolled patients from the pilot phase, and I invite you, if you have any patients between now and February 20th, as long as the REDCap is up and running, to start enrolling them. So all enrolled patients at this time will be added to the main phase. At this point, all questions and variables will be locked, and I have a lot of work to do with Amir the next couple of weeks to do that as smooth as possible. And of course, for the following year, which is going to be the main phase of the study, we will have no more modifications to REDCap, unless if there is a huge need for something very important and obvious. So there are a couple of more weeks, around 3 weeks, to reflect to us and give us some feedback in respect to your experience with REDCap, the new centers that we're going to start enrolling. And there is still some time to fine-tune things. Again, I want to make clear that we already have 9 domestic centers, many more international centers. For other institutions that have shown interest in the past, however, they were not able to complete the process of the ARB, it would be very difficult to join the study after the launching of the main phase. Amir, if you can advance one more slide. So in respect to collaborative centers that have already approved and they are ready to start enrollment are 12 international centers, including Argentina National Hospital from Buenos Aires, Argentina, Hospital General de Agudos. I'm not going to try to pronounce it in Spanish, Buenos Aires, Argentina. Hospital de Italiano, Buenos Aires, Argentina. So 3 centers from Buenos Aires, which is excellent. Emergency University Hospital from Bucharest, Romania. So now this is a center from Europe. We have another hospital from South America, Medical Hospital of Itauca, Paraguay. A second center from Romania, the Railroad Clinical Hospital of Cluj. We have a center from Iran, the Tehran University of Medical Science in Tehran. Universidad Autónoma de Nuevo León in Mexico. University Clinical Center of Kosovo. Institute Gastro Sciences, Kolkata, India. Another center from India, the Postgraduate Institute of Medical Education from Chandigarh. And finally, we have the University Sapienza from Rome, Italy. So as you can see, a great variation of centers from many centers from South America and Central America. I can count at least 5. Centers from Europe, I can count at least 3, and we're waiting from Spain. Our great colleague Enrique Di Mattaria to update us. Hopefully we'll have an IRB approval letter from Alicante soon as well. And then of course we have actually 4 from Europe. We have Kosovo as well. And then we have 2 centers from India and 1 center from Iran. Amir, if you want to go to the next slide. Registered centers, meaning centers that have provided us with a principal investigator and a research coordinator are 39. So as you can see, there is a remaining number of 18 centers that is still waiting for IRB approval and DUA, and these centers are still potential collaborators as long as they will be able to complete the process of the IRB approval within the next month or so. And next, we're going to move to REDCap, and at this point, I will we will switch gears, and Amir will take over. Amir, can you hear me?
Yes. Thank you, Dr. Papacristo. Thank you for your great information and your welcoming start of the webinar. Before the start of the webinar, I'm gonna welcome the attendees of this webinar. Right now, we have 12 attendees. With Dr. Papacristo, it's 13. Dr. Gula from Lithuania, thank you. Dr. Di Mattaria, as always, is in, and Dr. Gabriel Capruso, welcome. Dr. Jose Alberto Gonzalez, Dr. Marchi, Dr. Mario Pales, and Dr. Miguel Pereira Bogada, Dr. Narcis Ernesco, Dr. Gutierrez, Dr. Barbo, and one of the attendees, which I can just see the email address. I will appreciate if you just send me the name, Dr. Lorena Perna, if I just spell it correctly. And Okay, thank you for joining us in this webinar. For the rest of the webinar, I'm just going to go to very practical points to create REDCap and go through the questionnaire very quickly, just talk about very practical standpoints about the questions. And Dr. Papacristo is not muted and can just join us and add comment on each question. Just whenever you have any questions, as always, click on the hand sign in your GoToMeeting tab so I can see and just unmuted you to talk about it. Just feel free to talk anytime that you think is necessary. So as I sent you an email, we need to create an account in REDCap, and it should be created by yourself. I'm happy that up to this time, 6 participating center from the international parts just created the account over the past 2 days. And for example, Dr. Narcis Arnesco, Dr. Gutierrez, and 3 more person just created an account, and it's a very easy process. Dr. Barbo, I'm gonna just tell you, I sent you on this link. After clicking this link in your email, you'll see this page. The only thing that is a little bit confusing in the email section, our REDCap people has regulation that they prefer to have institution email address, and having like Gmail or Hotmail will be a little bit difficult. We can make exception in case that one of the investigators or coordinators are not easy to use their institution email, but in that case you have to inform me. Just send me an email and let me know that this person or that person needs personal email. Otherwise, honestly, it's a little bit easier for myself to use your institution email. And in the phone number section, please write our customer support phone number. It should be a number in US, so just write 412-624-8555. I've sent you this number in an email, and this slide and the webinar video will be available after the webinar, so you can use it. Then you use your username, and just in the comment section to navigate you to our project, you have to write CAPER Acute Pancreatitis Registry. And of course, just clicking joining the existing project. After creating this account, mostly after 24 hours, they will send you an email with instruction to create password. And then you can easily just join the REDCap login page. This is in that email that they will send you. You can find this link, and I can send you this link again in an email that I will do. Just you have to click in this link, and you will go to this page, which is a REDCap login page. And after using your username and password, you can log into your page. So right now, I'm gonna just go to my own REDCap account and go through a test case. And in this way, I think it's a little bit more practical to talk about real questions. Is there any question up to this time? Just
Hi, Amir. Still, I don't have the password.
okay, understand. Thank you, Dr. Zarnesco. Unfortunately, I received your creation of account yesterday evening, and it take 1 or 2 days. So you will receive this email with password instructions. So, but in case if you have any problem, just call me or just send me an email and I will figure it out. But unfortunately, over the weekends, they don't provide passwords, but it will be okay on Monday. Okay, so whenever you log into the REDCap, I believe all you guys are now seeing me on the REDCap page. Whenever you log into REDCap, you will see this page. In this page, you have to go to my project and choose the CAPER Acute Pancreatitis Registry. So now I'm clicking and go to the CAPER Acute Pancreatitis Registry. Honestly, it's a little bit complicated page, So don't be distracted with too many tabs and too many information. Mostly they are just things for settings and changing the information. What we need to go to add and edit record, which is in the left part as you can see, and click on the add and edit record. And then we can easily click on add new record, and now you're in. It's your first patient and you're starting to enrolling the patient. Before starting talking about the questionnaire and going our test case, I'm gonna just talk about some general rules that apply to our questionnaire. First of all, it's important to see what's the structure of our fields. You know, our questionnaire is categorized as different fields, and the reason that we categorize it in this fashion is because one of the main reasons for this registry is to enroll and collect the data prospectively. So we categorize the questions to the fields which is labeled by the day. For example, on admission, 24 hours, 48 hours, 72 hours, and day 7 discharge, delayed, and follow. In this way, you can just on each day go to the REDCap, fill the field, save it, and then on the next day you can go to the next field. This is so important, and because this is one of the main reasons that this registry has started, to have all the information prospectively. One of the other main reasons, okay. One of the other points that before starting the test case I'm gonna highlight is the opportunity to write comment on each question. Well, if you see on the left side of each question, you can see a yellow button that when you click on it, you can just comment on the questions. For example, in the etiology question, you can have a patient who have not matched to our choices. So in that case, you can just click on the yellow button of comment and write if there is any information more than the choices that we have provided you. And in the other case, up to the February 20th, it's a great opportunity to write your comments, and we can go through the comments and have the changes which is necessary to make our questionnaire more cleaner and more convenient to use. The other point that I'm gonna highlight at this point is the way that we have to collect this information. Apparently, there is two main ways. First is directly going to patient and interviewing the patient, and the second way is going to medical chart in terms of paper or electronic charts. We had an extensive discussion on this issue, and we ended up with some of the variables which is needed to go to the patient and ask directly from the patients. The reason that we set this rule in this registry is that based on our experience with proof study, we found that some of the information are not very accurate in medical charts. For example, for a clinician, the exact time of pain onset may not be that important. That is important for us. That's why in some question, if you go, for example, to the demographic part, you see that date and time of pain onset is in brackets. It means that this question should be go to the patient and ask directly via interview the patient. But there's some other parts, for example, the history of cholecystectomy, it should be go to the electronic or paper charts and understood from that part. This is another point, and while we are going through the different questions, you will see that one of the things that is very beautiful about REDCap is having a branching system in questions. Personally, I really like this thing because it saves lots of time. For example, if your patient is not smoking at all, you don't see questions about how frequent or how many cigarettes. For example, in the question, smoking question that you're now seeing. If I click never, you can't see any more questions. But if I just click active, you will see 2 more questions asking about the frequency of smoking. Another point that I'm gonna highlight before going to the test case is those questions which are required to be filled and we can't afford them to be missing. Dr. Dimaderia told me on Pancreas Fest that the most important role and most important and tricky part of registry is to have not too many missing data. And although it's very good, I'm just quoting from him, that although it's very good to have very large number of patients, but having lots of missing data will decrease the value of our data set. So we had a discussion with Dr. Papacristo and the publication committee, and we assigned some questions as a must provide values. And you can see these questions with a red line behind the variables that shows that this question should be filled. And if you are gonna save the field without filling this question, for example, right now I did not fill this part, and if I just click save, an alert pop up and showing me that these ones should be filled. So please do your best to fill this part because it's so important in our registry. Okay, so now I'm gonna go through a test case, and on each part we can discuss about questions, and if there is any question you can just ask and Dr. Papacristo can answer. In the first part, which is inclusion exclusion part, the first questions asking about your centers, please take your time and answer this part is important. Although your patients will be assigned to your center automatically, it was not like this. Just over the last few weeks we made some changes, so now after logging in, your patient automatically assigned to your center. But it will help us to navigate which center, how many patients from each center in terms of monitoring. To just click your center for the first question. In the inclusion criteria part, it's very standard inclusion criteria for acute pancreatitis. We have 2 main inclusion criteria, which is lipase or amylase more than 3 times of normal limit, and having abdominal pain, which is characteristic of acute pancreatitis. Having these 2 inclusion criteria is enough to enroll a patient, so no need to imaging if we have these 2 inclusion. In some cases, if for example the patient is intubated or lipase is borderline, or for whatever reason the history of abdominal pain is not very well documented, we can go to the imaging, contrast enhanced imaging, and with confirmation it is our 3rd included criteria. So having 2 out of 3 is enough to enroll the patient. Our exclusion is pretty straightforward. I'm not going to waste your time discussing about them. Just the only 2 points that I'm gonna highlight is having history of chronic pancreatitis and pancreatic cancer. And mostly the first one is a little bit tricky because there is a bunch of patients who are who have history of chronic pancreatitis. So mostly I personally go to 2 different ways to understand which patient have chronic pancreatitis. First of all, having a known history in consult by an expert, or having an imaging which clearly shows findings of chronic pancreatitis. And pancreatic cancer is another important exclusion that we have to be very careful to exclude those patients from this study. Now I'm going to go to the next field, which is demographics. In the demographic parts, most of the questions are straightforward. We will discuss if you have any question in the phone conferences that we will have. But one of the things that, most of the questions that I'm gonna discuss is based on our feedback after pilot phase. So I'm gonna just discuss more and focus on questions that centers had question and had problem with that. The date of pain, time of pain onset and initial presentation to the hospital is so important. I know that most of the participating centers in Apprentice are tertiary care centers, as we are tertiary care center in the University of Pittsburgh. So it's possible that there is a significant portion of your patient be a transfer patient. It's highly important to go to the primary center information and reveal the information based on the primary presentation. So in this question that we ask about date and time of initial presentation to the hospital, we just ask about the initial presentation to primary hospital, primary emergency room, rather than the tertiary center. We will ask about the time of transfer, but this is so important to go and look up about the information in the primary center. Based on our personal experience, we just call the primary centers and they will fax us the information. So we can discuss about it in any other innovative ways, how to get more information. I'm just gonna welcome Dr. Wiki Shing that joined us. Welcome, Dr. Shing. And the rest of the questions in the demographics is the question that you see. It's very typical of the question for pancreatitis. In the past medical history part, we ask a bunch of questions which is mostly required for Charlson score. And then social history and family history. Now I'm going to highlight that at the end of each field, you have an option to label your field as incomplete or complete. This is so important because whenever you have a missing data, please label it as incomplete. So later on, we can understand which field is not complete so we can track them. So this part is on your choice. You can choose complete or incomplete, but please, even if you have any question on any information, or for example the coordinator filled a question and he wanted to go and ask the investigator and make sure that it's correct, just this part is for your own sake to label the field as a complete or incomplete. And now I'm gonna just take a few seconds talk about how to save the records. REDCap information does not save automatically. So unfortunately, if for example your computer turn off suddenly, you will lose the information that you have filled if you are doing the field. So at the end of the field, ask about save options. You have 3 save options. You can save and continue. That I just recommend strongly to whenever you are just working on the field. Once a while, just save and continue. If you want to just answer a call or just go have a coffee, just save and continue. In the first one, which is big one, which is save record, you can save and just go out of the record. For example, if you want to just leave the data entry software. And in the last one, which is so clear, you can save and go to the next one. Okay, now we go to those part which is timely based structure on admission, 24 hours, 48 hours, and 72 hours. In this part, the most important questions are about vital sign and WBC, those which is mostly necessary for the serious score. One of the important point that I'm gonna highlight is the timing that we have to use. For example, in the on admission, we have just to mention those vitals which we found it as a first time. Heart rate, respiratory rate, or temperature at admission, we just recorded here. But at 24 hours, as we see, we go and pick the highest heart rate or temperature or respiratory rate between 12 and 24 hours. So it was a little bit tricky to me, because sometimes it's easy to have just 24 hours, but you have to go back and go to check within 12 to 24 hours which one is the highest one, and just go and pick one. So this helps us to calculate our CIRS score in the best fashion. And then we have just few questions on intravenous fluid therapy, which we do have it on first day. We mainly ask on 6 hours and 24th hour. As you see again, it's branching. So if you just click normal saline, then there is another question that pop up and ask about the milliliters of this fluid. As you can see, you can choose more than one fluid, and it is box and it's not like circle question, so you can choose more than one answer. Now I'm gonna just take a few seconds and talk about narcotics. Based on my own feedback, it was a little bit tricky for some of the coordinators. Of course, if the coordinators and the people who are just entering the data had a problem, I will be more than happy to contact and talk directly. We are just gonna record all narcotic data on a daily basis. So one of the things that we need is to calculate morphine equivalent dosage, because we need a consistent measure to compare different kinds of narcotics and having the same number with each center. So if, as you see, there is a very nice table that you can see for each brand name of morphine, fentanyl, hydromorphine, hydroxycodone, oxymorphine, or codeine, there is a specific equi-analgesic dosage. And then you can just divide the current narcotic dose to equi-analgesic number and then multiple 10 times. And this will give you morphine equivalent dose. So this is so important because for evaluating our pain system, it's important to understand how much narcotic have been used by the patient. Now, in the 48 hours, you will see the pretty similar questions. 72 hours, much more similar, and day 7. And now I'm gonna just tell you that after the discharge, we have a section for delayed drainage debridement and a section for follow-up. We define delayed as more than 2 weeks. So the best way to do the questionnaire is to start the enrollment. At the end of the enrollment day, just fill the admission and demographics, and the consecutive days each day go through the 24 hours, 48 hours, 72. If the patient is still in the hospital, 7 days. And then after 2 weeks, we have to go to the patient chart and see if the patient had any history of pancreatic intervention, including endoscopic intervention. It could be, as you can see, there is a branching, and if you say yes, it asks, is it laparotomy, is it minimally invasive surgery, is it percutaneous drainage catheter, or if it is endoscopy.
Amir.
Yeah.
It is also important here to realize that when we give the patient a follow-up phone call, this is also a question to ask if there was, because sometimes this intervention might not be done in the same hospital where the patient was hospitalized.
Mm-hmm. Yeah. Thank you, Dr. Papacristo, for your comment. And then in the follow-up section, we set up 3 months follow-up, but practically we see that it's not feasible to have exactly at the 90 days follow-up. So we set a time point of 60 to 120 days, and within this period, a follow-up, which is mainly phone call, it should be done. And if you're that lucky to find the patient in office visit, it will be okay. So you can see that you can choose office visit or phone call, or otherwise you can just give a call to a patient and ask about this part of questions. Up to this time, if any investigator have any questions on the REDCap or questions, Dr. Papacristo and I will be happy to answer it, and then we can move forward to the section for monitoring the data and exporting the data. Okay, it looks that I don't see any.
Hopefully that means that you did a very good job, Amir.
Thank you. Okay, so the only thing that I'm just gonna talk a little bit, I'm just checking my list to don't miss any important point, is about nutrition. In the nutrition part, I myself had a experience of working in a nutritional study, and I know that it's very difficult to capture and collect all possible information. There are different scenarios that the patient can come. So we ended up with this set of questions that ask about the nutrition. One of the most important things that I'm going to highlight, when we ask about the initial feeding attempt, it means just attempt. It could be successful attempt or it could be unsuccessful. So for example, if the physician started oral and the patient did not tolerate it, it's one attempt. So you have to just date it, write oral, whether it is what kind of oral, clear liquid, full liquid, whatever, and then yes or no, if the patient tolerated the attempt or not. We found that this is the only scenario, this is the only set of questions that we can capture all possible scenarios, and then again and again. And we finally asked about the exact date of oral tolerance and then capture the things. Just take a quick attention that this attempt does not mean that the patient should tolerate it and having oral fluid for 3 days and then it means that initial feeding. No, initial feeding attempt is just deciding and giving to the patient and tolerating or not tolerating. So at this point, if there is no question, I'm gonna just take a few minutes. Dr. Papacristo, Dr. Dimaderio asked, which is the definition of tolerance?
The definition of tolerance as far as the tube feedings or PO intake?
Let me just unmute Dr. Dimaderio. So, Dr. Dimaderio, you can talk right now.
And sometimes you give tolerance to give oral feeding to a patient, and in 48 hours he's 1 day without tolerance, or he starts to vomiting, but after that the patient resumes oral feeding. Sometimes this is difficult to make a proper definition of tolerance. In my database, in my Spanish database, I define it as more than 2 days tolerance of the diet, but I'm not sure if this is correct or.
I think that's a very good point, Enrique. And again, it's a gray area as far as how exactly to define it. I kind of agree with you. I mean, I would say at least 24 hours. If a patient is on PO feeding and has one episode of nausea and emesis, I wouldn't call that immediately intolerant. So what we can say, so as to be also matching our approach with the Spanish approach, is I would say at least 24 hours. So there are several, 2 or 3 attempts of PO intake that failed.
Okay.
Awesome.
Enrique, do you think we should do it 48 hours?
I did 48 hours, but it was just an option. I'm not sure which is the best. Maybe 24 hours is good, but if the patient, you know, starts to tolerate, he's eating for 24 hours and then we have a problem, maybe this is not tolerance. I have a patient now with that problem, for example, admitted.
And again,
maybe it's just a very specific case, but sometimes we
Exactly.
may have some doubts with that.
Again, if this problem is just for a meal, it's okay. But let's say day 3 or day 4, they start having nausea and vomiting repeatedly, and that exceeds the full 24 hours. I think
Okay.
at this point we could potentially call it intolerance.
Okay.
Thank you, Dr. Dimadir. I think it's a great point, and that having, it's very difficult to understand tolerance. So at this time, if there is any other question, I will be happy to have it, and just click on the hand sign of your GoToMeeting tab. If not, just I'm gonna take few other minutes talking about how to do export data and do reports and how to monitor your data. Well, as we have mentioned in the previous webinars, each center has access to their own data. I mean the patient that they're enrolled in this very same center, and they can do export the data in terms of Excel sheet or SPSS or in terms of whatever statistical software that you prefer. But the whole data set and the all patient pool is just accessible to the analysis and committee center, which as I mentioned, and Dr. Wikeshing, I can just have you the slides. Dr. Wikeshing, Dr. Gutierrez, Dr. Kochar from India, Dr. Dimaderia, Dr. Papacristo are our publication committee, and all the data is available for them. So in case of any idea, any thought, any idea of manuscript, this idea should go to the publication committee, and then publication committee assign a project to the center with all tables and statistics which is necessary for them. So, but in case of just having your own data from your center, you can just export it by clicking on the application part, which I'm now showing you, and then just click on the data export.
Amir, let me interrupt you for a second.
Yes.
The publication committee not only accept requests, but we will also have a plan of potential projects that we will be assigning to different investigators. So it's not, I don't want the investigator or co-investigators to get the idea that they have to come up with a project. But let's say we complete our enrollment and we have a very good number in 1 year, there will be multiple potential questions to be answered, and we can assign groups of hospitals led by one center per project, and we can provide them with the data required for the certain project, including data from all the centers involved, so as to move forward. The understanding, though, should be that this is an important commitment, and it's a time-sensitive commitment. So if a project is assigned to someone, to a center, and there's no progress at all in starting the manuscript within the next 6 months or so, this project might be removed for the certain institution and be assigned to someone else. And again, these will be decisions made by the members of the publication committee.
Thank you,
That's
Dr.
it.
Crystal. So just give you an idea how to export the data. You can just click on the data export tab, and then you'll see that you can choose how many patients, and then choose the software that you need for your analysis. It could be SPSS, SAS, or Stata, or it could be just Excel sheet. And you can just manage your export part in this section, and also you can just do statistics. You can have chart and graphs out of your patient or specific variables. I personally use this part to monitor how many missing data is present per centers. So for example, I go to demographic and then choose the date of onset, and then I can see how many patients are missing, for example, in each center, and then go and address it. So it's very useful part. I really recommend to use it. It will help you to save a lot and have a very clean data. And finally, there is a potential import tool which you can have your Excel sheet and then import it to the REDCap. But it's not recommended because it's very difficult to have the exact same structure and exact same design to be imported in a correct way. The only possible way is just to use our template, which you can see in the import tool. You can download this template and just fill the form based on that template. But again, I'm telling that it will be very difficult because, for example, in terms of date, if you even just miss one dot or just one dash, the REDCap will not be able to recognize it correctly, and it will come with lots of errors and problems. This is just like last resort in some centers they are not available to use REDCap for entering data, and they are just prefer to use Excel for filling the form. But it will be very difficult. We had a experience that it caused lots of mistakes and problems. Uh, Up to this time, I'm almost done with the just brief discussion of how to enter data and go through a test case. So if there is any question.
Again, Amir, a couple of very important points. Number one, the goal is not for each center to analyze their data and come up with projects through their data. This will be that our study and collaboration failed, correct? The whole point is every center that is interested in participating in a project and writing a project to be able to use the data from all the centers, the data of the study. This way the data will be much more robust and the quality of the paper will be much better. Now, I also want you to understand that some investigators are not very familiar with statistics or writing papers. This is completely fine. Even those investigators will be involved as co-authors in several projects. So their extremely important contribution in entering patients into the study will also be reflected into projects. Granted, the leading author of a paper will be the one that actually is writing the paper, but there will be many co-authors from the study. So I want you to make very clear that all the investigators involved in enrolling patients will have the opportunity to be involved in the projects, even as co-authors. And the second thing is, for our study purposes, we cannot do the Excel sheet that you mentioned. For our study purposes, and this is very clear, we have to go through the REDCap and do this entering of the patient as we discussed before through REDCap. That's why each center needs to have a REDCap account. So yes, this is a potential very risky option, but does not apply to our study. So I would have suggested not even to mention at all. We have to go through REDCap. Okay, Amir.
Okay, thank you. Any investigator, if there is any question, just click on the hand sign, so they'll be happy to hear you. Up to this time, we have 15 participants. Unfortunately, some of the centers just join us with phone and we can't track their names, so just accept our apologies that we did not say any welcome. But among 15 participants that I can see right now, thank you everybody just joining us on this weekend. Dr. Papacristo, do you have any other comments?
As we discussed, this is the time to really place the effort and the energy, keep up the momentum. We went through the ugly waiting process of getting IRB approval, set up the REDCap, do all the administrative steps that they are very important, but they are time consuming and boring and painful. So this is the time for each center to show their commitment into the study. We are extremely excited. We have placed an enormous amount of effort to reach where we are now. So we're throwing the ball at your side now. This is your time to show your commitment to the study, place the effort. I know at this point that we do not have funding. Down the road, hopefully we'll be able to have funding and things will be much more smooth and with the financial support. But at this point, again, I encourage you to place all your effort and energy, try to enroll as many patients as possible, not let patients go. Be very cautious and careful with the enrollment of the data. These need to be done in a prospective fashion so as to get the best quality data that you can. And I can guarantee you that if we do that, we're going to have an enormous gold mine in our hands a year from now, where we can establish our collaboration, the leading collaboration in the world in acute pancreatitis, and have and be very productive with publishing a lot of papers. So again, this is the time for you to show your commitment, place all your effort and energy to the study.
Okay, thank you. Dr. Narcissus Arnesco just asked that if the final version that it's in the REDCap is the same as the one in the APPRENTICE CAPER website. The answer is no. The questions are the same, but we did very few changes, just and we will do some changes after the pilot phase. So just I will send you the last PDF of the things, but the best thing is just to go to REDCap and have the final things. And Dr. Capruso, Dr. Barber, do you like to be unmuted and mention your questions? Right now you're unmuted, so if you like, you can just ask your question so everybody can hear your voice. But I can just read their question. They just send me a message that probably it will be difficult to enter a new field, but we use continuous epidural analgesia when patient is admitted to ICU. Could such a field be added? Dr. Papacristo, Dr. Barbo asked about possibility of continuous epidural analgesia to be added.
Yeah, I mean, this is part of the analgesics, and I think, do we have another option there? If we don't have another, we can always add another option with a possibility of mentioning what exactly sort of anesthesia is given. So we can always, if you can note that down, Amir, we can write down another option, and this can be also recorded.
Awesome. I just write it down. Thank you. I will add this part to the question. And just as I mentioned, you can always add comments to the questions if there is anything does not fit to our choices. There is another question that Dr. Gabriel Capruso asked, that Just a nice word, that very honest and transparent way, George. Ready to start to be proactive. Thank you, Dr. Capurso, with your encouraging word. And Dr. Dimaderia asked another question that indeed there are great differences between countries regarding analgesic. In Spain, we use metamizole and special NSAID. This is very important point that I'm gonna just write it down and add it. As I mentioned, we just left few weeks before the production phase to have your last comment. So if you have like another analgesics which is not available in our list, yes, please inform us and we can add it to the table. Dr. Papacristo, do you have any comments on Dr. Dimaderio question?
No, we should definitely add methimazole into the table, you know? We can investigate that and update it to the table.
Yes, it's a very great question. Any other question? Anybody wants to be unmuted? Right now, everybody.
Also, Amir, if there's any. Also, Amir, if any of the other publication committee members, Enrique, Sylvia, Vikesh, want to, you know, just say hi. And,
yeah, Dr. Vikesh, you are unmuted, so we will be happy to have your voice.
Hello?
Hello.
One short question. At my university, I have both GI surgeons and my department, the surgical one. If the patient is admitted in the GI and then transferred to us, is that considered to be a transfer? Because both clinics are actually enrolling patients.
No, since it's in the same hospital, I would say this is not a transfer, as long as you can have access to all the initial data from the medical floor.
Actually, they enroll as well for us. So
that's not a transfer. That's perfect then.
Okay.
Dr. Shing and Dr. Gutierrez, I will be happy to have your sound if it's possible for you. You're now unmuted.
I mean, they might not be able to talk right now, but that's okay. We appreciate their presence, and they can always send us an email or a text with their comments. So is it time to conclude?
Just one last question that Dr. Alberto Gonzalez asked, that what about the use of antibiotics for non-pancreatic infections?
Meaning if we're going to record that?
Yes.
I think we do have an extra pancreatic infection question, don't we?
We do, but he asked about the use of antibiotics for that.
You know, this is a very good point, of course. The important question is how, you know, every question that we add is an additional, you know, small, you know, piece of information that will make the process even a little bit longer. So the big question is how important is to record antibiotics for extra pancreatic infections. It's very important for pancreatic infections. And we can investigate that a little bit further and you know, and run it with the publication committee as well, see if this is something that we should include. But that's a very, you know, we appreciate his question.
And one last thing, Dr. Gutierrez just sent a text that I think it is very important to define all variables because of the differences between countries, as Enrique pointed. Yes, it's very important. That's why this few weeks it will be very important for all centers to place lots of efforts to give us this last final comments and feedbacks to, because honestly after February 20 it will be very difficult, almost impossible to change any question. So thank you, Dr. Gutierrez, for your great comment.
So the important thing, Sylvia, is at this point, I think sometimes the way that you guys, for example, in Argentina, approach and define things is different for what we do in the U.S., for example, correct? So it's very hard for us to get into your mind and see what exactly are the definitions that they might not be straightforward to you. So we're really looking forward to your input to let us know which are the gray areas, areas that into your practice are not very well defined as they stated, and we'll make our best within the next 1 month to to redefine, to refine this definition for you, so as to be able to enroll, with the same consistency between all centers.
Thank you, Dr. Parker. So Dr. Narcissus Arnesco and asked, give us a suggestion that it will be great to set time to discuss about some difficult cases of acute pancreatitis. I believe during he mentioned probably during the phone conference or the monthly webinar, a suggestion of discussing difficult cases of acute pancreatitis.
That's a great suggestion. We can definitely have cases discussed either through our Friday teleconferences, or even have one case per webinar as well.
Yeah, I just write it down, this great point. Any other suggestion or point? I can't see any other question. Just all participants are right now unmuted, so you're welcome to say hi or any comment. If not, Dr. Papakristo, you can just conclude the webinar.
Yeah, we're far beyond 1 hour. We are already 1 hour and 15 minutes, so I think it's time to conclude. Any more questions, you can always address them next time. Again, Happy New Year. Thank you for your participation and your interest and in the study. Now it's time to show to us your effort and commitment. Looking forward to hear from you and start having more and more patients enrolled. Thank you.